He's an attending physician at Tampa General Hospital, affiliate assistant professor at University of South Florida. Serves at the medical director for Hillsborough County Trauma Agency and the Tampa General Hospital Aeromed Regional Helicopter Program. He's also chairman of the Hillsborough County Trauma Audit Committee, board certified in emergency medicine by the American Osteopathic Board of Emergency Medicine. Please welcome Dr. Frank.
All right, thanks everybody. Thanks for having me today. Thanks for the introduction. My name is Marshall Frank. I'm an emergency physician at Tampa General. I'm the medical director of Aeromed, which is the helicopter program based out of that hospital. I'm on the clinical faculty of our emergency medicine residency program there, and we have an EMS fellowship that I'm on core faculty of. I completed that fellowship in 2013. At USF after I did emergency medicine residency in Miami. And I'm also a former paramedic. I worked in the Pittsburgh, Pennsylvania area as a paramedic and an EMT before medical school. So I'm very well aware of the difficulties and the hardships you have in the pre-hospital field. So I feel your pain most of the time. So I'm here to talk to you today about PEA, Pulseless Electrical Activity, specifically the differential diagnosis and management of PEA. And even more specifically, the management of reversible causes of death causing PEA. So let's go ahead and get started. I have nothing to disclose financially. Like I said, I'm the medical director of Aeromed, which is through Tampa General. For those of you who aren't familiar with Aeromed, we have 4 helicopters throughout the West Coast and central part of the state. We fly, 3 of our 4 bases fly Bell 407s, which are the first 2 helicopters here. And then one of our bases, Aeromed 1, which is based out of the hospital, flies a BK-117, which is a bit bigger of a helicopter. We fly about 1,600 missions a year between, it's a pretty even mix between pre-hospital scene calls and inter-facility calls. So that's Aeromed for you. So my objectives today are to talk to you about PEA. I want you to consider a new way to learn, teach, and manage PEA. And at the end of the talk, I want you to understand differential diagnosis and management of both narrow complex PEA and wide complex PEA. And as you'll see, what we're going to do is divide PEA into narrow complex and wide complex in terms of the QRS complex. And what I should add as the 4th objective is I want you to stop using the H's and T's that were taught in ACLS. So I want you to improve patient care by sort of thinking of a different algorithm and different way to think of and manage PEA. But as always, if you read any of these outreach articles that I write, just make sure you follow your protocols and do as your medical director instructs. So don't take my word as gospel. So the first 4 slides or so are a little bit boring. I have to apologize. And basically what we're going to do is define PEA. We're going to talk about management. We're going to talk about pathophysiology. And so just bear with me for a second. I know none of us like pathophysiology. So the PEA is defined by Tamponade. Tamponade is one of the big textbooks that we use in emergency medicine residencies. PEA is defined as an organized rhythm without the presence of a detectable pulse in a patient that's in cardiac arrest. And the pathophysiology, so don't let your eyes glaze over here. We're going to come back to this slide a couple of times, unfortunately, is an underlying cause. The underlying physiologic cause of PEA is either a marked reduction in cardiac output due to either profound myocardial depression or reduced venous return and impedance of blood flow through the cardiovascular system. So we're going to see it's one of 2 things. It's either the heart's not pumping well or there's a mechanical obstruction. Okay, so get to know this slide well because we're going to come back to it a couple of times. Prognosis, just like any other cardiac arrest syndrome, is poor. 2% of patients only will survive to discharge. Maybe that'll improve after this talk, maybe not. Okay, and then the management of PEA is really guided at identifying the underlying cause and managing the underlying cause, which we're going to see. So I'm going to give you 3 cases, and what I want you to do is picture yourself at the scene of this call. You're going to have very limited information, but I want you to think about how you would manage these patients, what you would do, in terms of management of these patients and how you can improve their outcomes. And I want you to think a little bit further than just intubation, high-quality continuous chest compressions, IV O2 monitor, epinephrine. Think a little bit further about the differential diagnosis and how you can manage them to improve their outcome. So the first case, I'm sure we've all seen this, 47-year-old guy involved in a motor vehicle crash. GCS is 4, he's 150 kilos, so like 300 pounds. Blood pressure is good, 110 over 72, heart rate of 110, SpO2 98%. So you intubate him, right? GCS is 4, and you put him on positive pressure ventilation on your ventilator or bag valve mask, whatever. 4 minutes later, the blood pressure is 70 over 30, and you think, you know what, this is probably post-intubation hypotension. Let's give him some fluid, he'll get better. He doesn't get better. 2 minutes later, there's no pulse, and then this is what you see on the monitor, right? So narrow complex PEA, sinus rhythm, but narrow complex, no pulse. So just think about, this is all the information you have. Think about how you would manage this patient and what you can do to manage reversible causes of death. Because in each of these cases, you're going to see you can manage reversible causes of death. Second case, 76-year-old guy found at home by his wife. And the wife says, you know what, my husband hasn't really been feeling well the last couple of days, so he hasn't made it to his medical appointments. That's all the information you have. You put him on the monitor, he has no pulse, and this is what you see. Okay, so again, instead of just thinking about intubation, chest compressions, IV O2 monitor, epi, which you should be thinking about, but think about what can you do for this patient to improve his outcome, and manage reversible causes of death. Last patient, 29-year-old female found unresponsive in bed. The patient has a weak pulse when you get there, but she's quite hypotensive. You get a 12-lead EKG. Shortly after that, she goes into PEA. But before she went into PEA, this is the EKG that you had. Okay? So just, again, think about how you can manage this patient, how you can manage reversible causes of death. So most of you, since these are all PEAs, and this is what we're talking about, are thinking about the H's and T's of, I guess you could call it H's and T's of ACLS or a PEA. And so in ACLS, we're always taught these H's and T's. And ideally, most of you are trying to name them, right? But we're all sitting in a comfortable environment, not very much stress, under no distress. And I can guarantee you most of you probably weren't able to name them. When I was writing this talk, I couldn't name them. I had to reference the H's and T's multiple times. And even if you can name the H's and T's, who cares? And I'm going to show you that just simply naming these H's and T's doesn't really do anything for you. So you can name them, big deal. What's the significance? And most importantly, how does it help us manage our patients? Okay? So, like I said, sitting in this room, comfortable, no distress, you probably couldn't manage the H's and T's. We all know when we're under distress, our ability to recall lists and sort of stupid things isn't really good, especially at the scene of a call like this. This is a call that we flew a patient out of, I think in Hillsborough County. This was a man and a woman who were fishing on some sort of a private land. They were approached by security. They fled the scene, probably because they were not doing something they were supposed to be doing. And apparently at a very high rate of speed, they fled the scene. Because this is the result, and I'm not very familiar with car anatomy, but I think this is the cab where you sit, and this is the chassis, or you can correct me if I'm wrong. But anyway, regardless of your knowledge of cars, the car's in pieces, literally. And so imagine, and this was a patient that was found in PEA, imagine having to deal with this, and then you're thinking about these H's and T's and how to manage the patient, right? The outcome of the patient isn't going to be improved by that. And I want to show you something else. I was introduced as the medical director of the Hillsborough County Trauma Agency. That was true up until April of this year. I served in that role for 3 years, and I voluntarily stepped down because it was just too long. I had too much to do. But as the medical director of that agency, I had the opportunity to review a lot of cases, ME reports, pre-hospital cases, and so forth. And just to show you, if you feel like you don't get respect from hospital personnel, from ER docs, from whoever else, nurses, just understand that what you guys do is exceedingly important and difficult. And so if you want to, you don't have to read this whole thing, but what I want to bring to your attention is, can you see it highlighted there? Good. So what this says, and this is a very well-written chart, the patient was then extricated from the scene through mud holes and tall grass, and the tall grass was snake-infested grass, into the rescue. So I have to tell you, I wouldn't have gotten out of the ambulance or the helicopter or anything like that. So more power to you guys. So anyway, imagine thinking of these H's and T's, which I'm going to tell you not to do anymore, in this situation where you're bringing the patient through snakes. I mean, I barely remember how to walk at that point, I think. So anyway, so here's the H's and T's, and I'm going to just go through them. Hypoxia, hypovolemia, hydrogen ions, which is acidosis, not very helpful. Hyperkalemia and hypokalemia. So in my opinion, that sort of crosses each other out. Hypothermia, hypoglycemia, the T's, toxins, tamponade, tension pneumothorax, thrombosis, which is a big MI or a big PE, and trauma. And just so you don't think I'm making that up, this is a snapshot right out of ACLS. If you have any questions or anything, just stop me. We can make this very informal, even though it's a very big room. So my goal is to have you stop the use of these H's and T's. And I'm going to go through everything, each one of the H's and T's, and tell you why I don't think they're important, why I don't think they're necessary, and why I don't think they help our patients. I'm going to do so by using this sort of algorithm. We'll just call it an algorithm. It's not really. This was a study in a paper in 2012 in Medical Practices and Principles. And basically what it does is breaks PEA down into two categories. It breaks it into into narrow complex PEA and wide complex PEA. And remember, going back to that pathophysiology slide, we said that there's two causes. It's either a mechanical cause or it's a problem with the heart not being able to pump, profound myocardial depression. And basically what you'll see is the narrow PEA is a mechanical cause, and the wide PEA is a myocardial depression. And we'll go over this in great detail. And this is the paper that this study was in 2013. And so I'm just going to list this, and this is going to be a little bit boring too, but I want to list each of the H's and T's and tell you why they're not important and how they don't help manage our patients. So I'm going to start with hypovolemia. When was the last time you got on the scene of a cardiac arrest and the patient didn't have bilateral 16-gauge IVs, or IO, or some sort of IV access or IO access, and isn't just automatically given fluids? I think we can all say that that happens automatically. We're trained to do that. We don't have to think about it. So you can stop thinking hypovolemia as your cause of H's and T's because you're addressing it automatically. Same with hypoxia. We, as emergency providers, love to intubate. We love to ventilate. We love to play with the airway. When I was a paramedic, if somebody told me they were going to take away my ability to intubate, I would probably have quit. So this is a very important thing that we do. We're good at it. We're trained at it. So hypoxia, you're not going to show up on the scene of a cardiac arrest and not have somebody at least being bagged. And if that's the case, maybe your partner and you should go back to school or something. So let's take hypoxia off. Hydrogen ions, this is not helpful at all. Something that we're going to do in the field isn't really, we're not going to address acidosis directly in the field. We're going to do high quality chest compressions. We're going to give volume resuscitation. We're going to ventilate. So hydrogen ions, again, something that we do automatically. We don't really routinely give sodium bicarbonate. So this is something that we can take off the table. Hypo and hyperkalemia are a different story. I think we can take hypokalemia off also because it's not a very common cause of cardiac arrest. We won't know if the patient's hypokalemic based on anything, including history, in my opinion, unless they give you a history that they had a ton of diarrhea and then they went into cardiac arrest. But I don't think you guys carry potassium, right? So it doesn't really matter for us. Hyperkalemia, on the other hand, is something that's important. So I'm going to circle it and we're going to come back to it. Hypothermia, same thing. We feel that the patient's cold. In our protocols, we put one of these looks like tinfoil blankets around the patient, no matter what. We even measure the temperature. But if you feel the patient's cold, you're going to touch them, you're going to warm them up. Hypothermia, off the table. Hypoglycemia, I think all of us automatically check a finger stick glucose. We can just remove that because this is something we do automatically. And if they're hypoglycemic, we're going to address that. Now, when you talk about toxins, so if you're sitting at the scene of a call and you're listing the H's and T's and you get up to toxins, Just by saying toxins, again, this is why I think the H's and T's aren't very helpful, because you're going to say toxins and it's going to be meaningless. You're not going to know what toxin, you're not going to know how to treat it, so you're basically stressing yourself out, coming up with this list that isn't helping you, probably making you more stressed out, and certainly isn't helping the patient. So what I'm going to do is make a sort of a pinkish line through that, like a little bit lighter of a line, and circle it, because we'll come back to it. I put a question mark next to it so we can think about what's the toxin. Because toxin is an important part of what we're going to talk about, but we need to have a little bit more information than just saying toxins. And then, like we saw in the algorithm, tamponade is certainly an important part. Tension pneumothorax is certainly important. And then I'm going to cross out thrombosis, both coronary thrombosis, so acute MI, and pulmonary, which is a big pulmonary embolism, because it's nothing that we're going to really address as a reversible cause of death in the field. If we see somebody that has ST elevation MI on their EKG before they code, we know that they're going to need to go to a center with PCI capability. A big PE, we don't give thrombolytics in the field. If the history is right and the patient's in cardiac arrest in the resuscitation bay, maybe we give thrombolytics in the emergency department as a last ditch effort. The literature really doesn't support doing that, but sometimes we do. So again, to make it simple, we're going to take thrombosis off the table, because it's not going to affect really what we're going to do acutely in the field. And then trauma we can get rid of, because we've addressed everything that's going to cause cardiac arrest and trauma. We're going to address hypovolemia, and as we'll see in the upcoming talk, we're going to address tamponade and tension pneumothorax. Okay, so again, you're going to say trauma out loud as an H&T, and it's not going to help the management of the patient. So here's this algorithm. It's sort of an algorithm that I propose we talk about more. And really, again, like I said, it breaks PEA into narrow complex PEA and wide complex PEA. And the things that we're going to be concerned about in the field that we can manage, that we can address reversible causes of death. For narrow complex, it's cardiac tamponade and tension pneumothorax. And for wide complex, we're going to talk about severe hyperkalemia and sodium channel blocker overdose. Okay, and the rest of them, really, we can eliminate. Not that they're not important, but we don't have to worry about them so much, because it's nothing we're going to address in the field. What I would counsel you to do is to really focus on things that we can address in the field. So pulmonary embolism, yes, it's important. We're not going to really do much about it in the field. Acute MI, yes, it's important. That patient needs to go to a PCI center if you suspect that is the case, but nothing that we can address directly in the field. Okay, and then just going back to toxins, as we see in the algorithm, toxins is sodium channel blocker toxicity, which we'll go into detail about. Okay, so let's start with narrow complex PEA. And really what we're focused on with narrow complex PEA is, again, cardiac tamponade and tension pneumothorax, because these are things we can do something about. We can manage these disease processes in the field and hopefully have a good outcome. So going back to the pathophysiology slide, I promised we would. Remember, we broke it up into two main causes: myocardial depression and mechanical factors that either reduce venous return or output. And so what we're going to talk about with narrow complex is mechanical factors that reduce venous return or impede blood flow through the cardiovascular system. And specifically, what we're going to talk about is venous return issues. So if you talk about factors that impede blood flow through the system, that's more like a PE. We're going to talk about a pulmonary embolism. And again, like I said, we're not going to really address that too much in the field. So what we're going to address is factors that reduce venous return. And again, those things are cardiac tamponade and tension pneumothorax. And we can address those easily in the field by doing pericardiocentesis, if that's in your protocol, and by decompressing the chest somehow, some sort of a thoracostomy, needle thoracostomy, finger thoracostomy, tube thoracostomy, something that'll decompress the chest, open the chest, and eliminate that tension physiology. So let's start by talking about tamponade, cardiac tamponade. There's a lot of causes of tamponade. The ones that we're most concerned with is blunt trauma from cardiac arrest or aortic dissection. Regardless of the cause of the tamponade, you're having a lot of fluid and pressure accumulate within the pericardial sac. Other causes are malignancy. You can get metastatic disease to the pericardium that causes bleeding into the pericardium. End-stage renal disease, we see all the time. Patients with uremic effusions have these huge pericardial effusions, and they're doing just fine. And then pericarditis, they get like friction and inflammation that causes effusion, and then of course trauma. So, not to talk more about pathophysiology, but the cause of tamponade is intrapericardial pressures rise so much that it really it crushes the right atrium and the right ventricle, and they can't fill with blood. And that reduces significantly cardiac output and leads to cardiac arrest and death. If you prefer to look at pictures, this is a picture of tamponade. You can see the heart sitting within the pericardial sac, which is this, and then there's a lot of fluid around here, and all these forces are pressing on the heart, and the right ventricle is pretty flimsy, gets pushed in, and it doesn't fill with blood, so you have no cardiac output. So you have right ventricular collapse, and then cardiac arrest, and then death, which is bad, which is what we're trying to prevent. This is an ultrasound image of somebody in tamponade. You can see here a rather large pericardial effusion here. This is the heart here. This is the effusion. This white, brighter part is pericardium. And then you can see this is right atrium, and what would be here is right ventricle, but there's so much pressure from the pericardial effusion that the right ventricle is collapsed and can't fill. So this patient's in tamponade and probably about to die. An interesting part of tamponade, when you talk about it, I'll just talk about this very, very briefly, is this curve here is a chronic effusion. So like somebody with end-stage renal disease has this huge pericardial effusion, they're just walking around with it all the time. And this is from an acute effusion, so let's say trauma. And you can see that really this guy here, with the amount of fluid he accumulates, and this is pressure on the y-axis, he can tolerate much higher fluid volume in the pericardium and have lower volumes than this guy who has an acute effusion, can't really tolerate volume in the pericardium. And if you've ever seen a pericardial effusion that has tamponade physiology drained, you can see, like, we'll drain 30 cc's, 40 cc's, 50 cc's of blood from the pericardium, and the patient's blood pressure will go from like 40 over palp to like 120 over 80, just by draining a very, very small amount of fluid. So just to understand the difference between a chronic effusion and an acute effusion is a big deal. But regardless of that, just knowing that you can drain 20 cc's of fluid, 30 cc's of fluid off the pericardium, these patients do exceedingly well. And that's exactly what that slide says. So this is how we do the procedure if you're not familiar with it. If you do it blindly, you go through the subxiphoid. Usually we use a spinal needle into the pericardium, drain fluid, and they do fine. Nowadays in the department, we do it with the ultrasound, so we go transsternal, or just lateral to the sternum approach, and these patients do fine. Okay, so that's cardiac tamponade. And again, what we're talking about is a narrow complex PEA. And the differentials that we're discussing with narrow complex is cardiac tamponade and tension pneumothorax. And the management is pericardiocentesis, and as you'll see, thoracostomy. So just going once more back to this pathophysiology slide, we're going to talk about tension pneumothorax. And again, that's a factor that's going to reduce venous return by a mechanical factor, by shifting the mediastinum. This is the pathophysiology of tension pneumothorax. I'll let you read it, but I think we all probably understand the concept of that. So basically what happens is that you develop so much tension, it pushes the mediastinum, which is the heart, the vena cava, the aorta, everything over to the opposite hemithorax, and you have an x-ray that looks like this. So this is a very bad tension pneumothorax. This is a post-mortem x-ray. And you can see rib fractures here, right? So one could probably feel this, and there's subcutaneous air, so you can feel like the crunchy, sort of like Rice Krispies on the skin. And then important to note here, if you're not used to reading radiographs, this patient's intubated. This is an endotracheal tube in the trachea, and it's shifted over. But you can see the whole mediastinum shifted over, the heart, the great vessels, everything, huge tension pneumothorax. And the importance of recognizing that this patient's intubated is that he or she may have had a simple pneumothorax, meaning just a bit of a dropped lung, before he or she were intubated. And then they get intubated, and it's just like blowing up a balloon. You can change a simple pneumothorax to a tension pneumothorax within minutes. Okay, so just beware when you're intubating people from trauma that you think may have a pneumothorax to begin with because of the exam. They have crunchy skin, they have rib tenderness or something like this. Just make sure you consider and watch very closely for development of tension physiology. This is another X-ray of a tension pneumothorax. And people always say that you should never diagnose tension pneumothorax on X-ray. The development of tension tracheal deviation is a very late sign. JVD, is probably a late sign. You have to base it on vital signs, on the patient's symptoms, and if they're deteriorating. So looking at the trachea and the JVD, in my opinion, isn't really all that helpful. So this is another tension physiology. And again, just like I said, tension physiology can develop very, very quickly in an intubated patient undergoing positive pressure ventilation that has a pneumothorax. So in chest trauma, anybody you suspect that has a simple pneumothorax, just be very, very wary and watch them very closely. Okay, and the treatment is thoracostomy. So needle thoracostomy, simple thoracostomy, which I'll talk about more, or tube thoracostomy, which is a chest tube. Okay, and that's what that side says too. So let's talk about needle thoracostomy. And I want to just talk about the failure rate of needle thoracostomy. The literature says up to 65% of failure rate for thoracostomy success if you use an 1.5 inch needle. Okay, I don't know, if anybody wants to shout out if you have a specific needle that you use if you do needle decompression, but this is for an 1.25 inch needle. 65% of the time it's going to fail. So that means you have a suspicion that the patient has tension physiology. You can perform a life-saving maneuver, which is decompressing the chest, but 65% of the time it's not going to work, and the patient's going to die, right? Because they're going to die quickly from tension, if that's the case. So this is a picture of angiocaths. That's an 1.25 inch needle, and the other one's a 3-inch needle. For some reason, like everything else in medicine, we talk about centimeters. When we talk about angiocaths, it's in inches. I'm not sure why that is. So what's also interesting is ATLS guidelines specify, and this is right out of the book, the use of a 5 centimeter or 1.96, so let's just say 2-inch 14 gauge angiocath over the second intercostal space at the midclavicular line for needle decompression. And they say specifically that it's reported, however, that when utilizing the 5 centimeter or 2-inch needle for the anterior thoracostomy, based on CT, so they're basically measuring the size of the chest and predicting if the needle will go into the pleura. Based on that, they expect it to fail 42% of the time. Okay, and that's using, this is the standard IV needle, so that's using a bit of a longer needle, 1.96 inches. So, I mean, that's to me unacceptable. 42% of the time that you have the potential to reverse, to manage a reversible cause of death, and 2% of the time you say, we don't expect it to work. So this is a study out of the Journal of Trauma in, I think, 2000, I forget what year to be honest, but this is out of the Journal of Trauma. And basically what they did was compare needle sizes, and the clinical effectiveness is improved using a longer angiocath, which isn't very surprising. I think we could all have guessed that. But they compared 8 centimeter, so 3-inch angiocaths, versus 5 centimeter. Again, remember the 5 centimeter one is the one recommended by ATLS. And basically by increasing the length, it increased the effectiveness of the needle thoracostomy. And they defined effectiveness by clinical outcome. So not that it entered the pleura, that the patient, but they defined it that the patient did better after thoracostomy. And you have to keep in mind that maybe they didn't have tension, and maybe there was something else going on, but the patient improved significantly more using the longer needle, meaning that the needle's getting in there more frequently. Okay, 83% of the time versus 41% of the time. So what this shows is that if you're going to decompress the chest with a needle, you should use a longer one, which makes perfect sense. They also measured the chest wall thickness and tried to predict whether they thought the angiocath would get into the pleura. So for the 5 centimeter one, at the midclavicular line, so the ICS is intercostal space, MCL is midclavicular line. So at the second space, midclavicular line, the 2-inch needle got in there 80% of the time based on what they were measuring, and and it got into the pleura 53% of the time at the fourth space, the mid-axillary line. The longer one, the 3-inch one, they predicted though 100% of the time at the second space, 90% of the time at the fourth space, the mid-axillary line. So that's good, but still you're having only an 83% of the time you're having that it's more effective. But again, that other 17%, maybe the patient didn't need that procedure. The problem with the needle is, I'm sure you guys have all experienced this, it's unreliable. You don't know whether you're in the pleura. You don't know whether you diagnosed tension physiology appropriately and just didn't do the procedure right because the needle wasn't long enough, or you just didn't get into the pleura. Also, the cannula kinks, it clogs, it compresses. You're constantly managing that, right? So the patient deteriorates, you're re-needling the chest. We see patients come in with like 6 needles across their chest. And you're dealing with it a lot, right? So you're managing that patient's chest a lot of the time, and you have very limited resources. So it's an issue with time management. And it also lacks certainty. So if the patient doesn't improve, do they not improve because they didn't need the thoracostomy, that you misdiagnosed tension physiology, or did they not improve because you didn't get into the pleura? And you don't know, and that's not a good situation to be in. So that's why in Aeromed, about a year ago, I think, or so, we introduced finger, or it's also called simple thoracostomy, which is just putting a finger in the chest instead of a chest tube. So when you put a chest tube, you dissect the skin, you puncture the pleura, and you put your finger in there, feel the lung, and then you put a tube. So we do everything up until putting the tube. It's called simple thoracostomy. And really the idea is just to open the chest, decompress anything that's going to be life-threatening, and then move on. So, and the reason we do it is that it's fast. We can get in there and we train a lot on it. We can get in there in a matter of seconds. You can feel the lung expanding on your finger. Once you get your finger in there, you feel the lung, you know you're in there. So whether you misdiagnosed it, overdiagnosed, or whatever, you know you've addressed a reversible cause of death in a patient that is either about to code or is coded. If you need to, you can put your finger back in. Which we usually don't because it's a big enough hole. And instead of doing a tube thoracostomy, we avoid placement of a foreign body in the field. And that can lead to empyema and infections and other kinds of stuff. So we just keep it as simple as possible. And usually when we do it, the trauma service, when we get there, or the emergency physicians, just put a tube in the hole that we used. This is how we do it. I'll just very briefly discuss it. We just find what's called as the triangle of safety, which is the fifth nipple, the latissimus dorsi muscle, and the pectoralis muscle. We make a cut. We have a kit that we have a scalpel and some Kelly clamps that dissect the skin, puncture the pleura, stick our finger in there, move our finger around, feel the lung to expand, and then move on. What we always do also is then label the thoracostomy site. Okay, so make sure you use the right terminology. It's thoracostomy when you put a hole. This guy looks like he got run over by a train also, but I don't know what happened. But this is the thoracostomy site, and we circle it and label it. Just so if the patient goes to the ME, they don't think they got stabbed. If they go to the OR, they don't think they got stabbed. So everybody's on the same page, and we label it. We circle it. If we do like a really good job, and we think we saved the patient's life, we circle it and label it Aramed. If we think we like messed up and didn't need to do it, we circle it and label it with LifeNet 5 or, you know, Bayflight or something like that. But that's what we do. Okay, so that is narrow PEA. And really all we're dealing with are two things: tension pneumothorax in the right clinical setting and cardiac tamponade. And you know, just remember this is in the correct setting. Ventilator management comes up on this a lot. This is something that's like if the lungs are hyperinflated from, let's say, COPD or asthma, there's some teaching that you disconnect the ventilator circuit and just like press the chest just to decrease hyperventilation. But I don't think our patients are being ventilated for all that long, so it's nothing we need to deal with. Any questions on narrow PEA? I think we're doing okay on time. I'm going to move on to wide PEA. And wide PEA, really, just like narrow PEA, two things we're focusing on: severe hyperkalemia and sodium channel blocker overdose. Okay? And so now we're moving away from mechanical obstruction. We're moving into myocardial depression. Okay, I told you this pathophysiology slide would come back a couple of times. It's not as boring as we thought it would be. So we're talking about severe hyperkalemia, sodium channel blocker overdose. And the management is quite simple. Usually you may or may not know the etiology. Is it potassium? Is it sodium channel blocker overdose? So you can really treat them for both, you know, if it's in your protocol, or treat them for the one that you suspect more. And the treatment is calcium for hyperkalemia and sodium bicarbonate for sodium channel blocker overdose. And really what you want to give for sodium channel blocker overdose is sodium. There was an article, I think on Monday, in the New York Times in the business section front page that sodium bicarbonate is in short order. So just keep in mind, if that happens, that what you're looking for is the sodium. Okay, and so let's talk about severe hyperkalemia. That's one of the two causes of wide complex PEA that we're going to deal with. Hyperkalemia, we see it in people with end-stage renal disease. So if you get on the scene of a call, PEA, you know, it's always good to check the arms for a fistula, check the chest for a dialysis catheter. That'll help to lead you into thinking what's going on. Severe acidosis, we see hyperkalemia, and medications like spironolactone, any sort of sodium channel blocker, potassium sparing diuretic. And then later on in rhabdomyolysis, you get muscle breakdown. This would be more like in the hospital setting. Hyperkalemia, you're going to see EKG changes. Sometimes in textbooks, they list EKG changes down, sort of a list as to what you can expect. In my experience, that's not the case, but I think we're all taught about peaked T waves, prolongation of the PR interval. Basically, you're just picture the EKG widening out and then eventually developing a sine wave. A sine wave is like up and down. And here's what some hyperkalemia looks like. These are from the internet. I have a cool case that I saw the other day that I put in here. So let me just show you this. These are the peak T waves that we're all taught, you know, but we don't have to worry about this if the patient's this patient wouldn't have PEA yet. But they can develop from peaky T waves to a sine wave in PEA very quickly. So if you have an EKG first and then the patient deteriorates, you know, consider this. You know, you got these pokey T waves, look like they're gonna make your finger bleed. And then you can see the QRS widening out more. You lose the P wave, and then, I don't know if that's familiar to anybody, but you get wider QRS, very long PR interval, and then eventually a sine wave. And I had this case the other day on a Wednesday morning. On Wednesdays, our residents go to grand rounds, so the attendings work all by themselves. And I had this case. This is a Wednesday morning, can you read that? What is that, 7:32 in the morning? My shift started at 7. So as any good ER doctor, Dr. Banerjee could probably back me up on this. You see this EKG, and really what you want to do is sign it out to your colleague who's coming to relieve you. But this was 7 in the morning, and I started 30 minutes before, and nobody was going to come do that for me. So anyway, this looks like VTAC. It's not. It's very, very wide. in this patient that missed dialysis. So let me show you. This is 7:32 in the morning, okay? And I repeated it, hoping maybe it would get better in 10 minutes, and it didn't get any better. And the patient missed dialysis, so I said maybe it's hyperkalemia, and I treated it. Oh no, oh yeah, good. And then here's the treatment after calcium. So you can see that, 20 minutes later, the QRS narrows, and the patient went from what looks like VTAC, and can be easily confused with VTAC, but this is hyperkalemia. The patient's potassium was 7.9, normal is like up to like 5 or so. This is very high. And anyway, the treatment is calcium. So I gave this patient calcium, and it made that EKG much better, and that was it. In addition to calcium, so the calcium we give to stabilize the cell. You also want to push the potassium into the cell. We do that with insulin, and you want to remove the potassium from the blood. So we do that with diuretics like Lasix. They can pee it out if they don't make urine. We take them to dialysis right away. And K-exalate is a drug that we use to poop it out, but we don't really use that so much anymore. So you want to stabilize the cell, push it into the cell, and remove it. So that's hyperkalemia. So just knowing calcium, is what we're talking about. And then let's just move on to sodium channel blocker overdose. I'm going to go a little bit faster because there's a case I want to present at the end, and I've been here for 44 minutes. So sodium channel blockers, the most common or the most thought of, and basically the one that we teach everybody is TCA overdose. We don't really see TCAs that much anymore, but people know they can overdose on them, and I don't know how often we see that. I don't see it very much, but they block the sodium channel. And really, any antiarrhythmic on the a 1C antiarrhythmic like flecainide or propafenone, these are sodium channel blockers. And I sort of promised I wouldn't talk too much about pathophysiology, but this is one more slide on it. And I'm going to go quickly through it. Basically, it blocks the sodium channel, and it decreases the sodium exchange, and you have decreased myocardial contractility. That's how it happens. EKG manifestations. What you'll see is a sinus tachycardia. If it develops sinus bradycardia, it's a very bad sign, because usually this comes with an anticholinergic syndrome. So you get like hot, they get tachycardic, they're dry. So it's a lot like some sort of a anticholinergic overdose. And what you'll see in EKG is in AVR, you'll have a big terminal R wave, so greater than 3 millimeters. And this one's like 4 millimeters, a big terminal R wave in AVR. Okay, so if you see that in the right clinical setting, that's what you would be concerned about. And like I said, clinical manifestations, they get agitated, tachycardic, they're dry, urine retention. These are all anticholinergic syndromes. They can have a seizure, they can have hypotension, they can go into cardiac arrest. And the management, if you're suspicious for this in the right setting, is sodium bicarbonate. And really what you want is the sodium. So I'm sure you can use like high tonic, higher percent sodium, like 3% sodium normal saline or something like that. But you're looking for the salt. And basically the salt displaces the drug from the receptor and makes it better. And you give it in boluses until the QRS narrows. Okay, so that's wide complex PEA. So again, consider wide complex PEA in somebody that's severely hyperkalemic and TCA overdose. Questions or anything? Okay, so let's go back to these cases. So hopefully after hearing what I had to say, you can think about these cases differently. Think about what you would do, again, more than airway, breathing, circulation, IV, IV access, O2 monitor, epinephrine. Think about how you can manage these patients to manage reversible causes of death. So the cases for some reason are out of order from how I presented them first, but this is the case of the 76-year-old man who was found by his wife. He hasn't been feeling well. And he hadn't been going to his medical appointments for the last week. He's in cardiac arrest. You put him on the monitor. That's what you see. So now that we talked about this more, does anybody have an idea what maybe this patient's issue is? Yeah, right, hyperkalemia. So he hasn't been going to his medical appointments, and he's hyperkalemic, and so you can give him calcium. Hopefully he'll get better. Case 2, this young girl found unresponsive in bed, weak pulse, you get an EKG, she develops cardiac arrest, and this is the EKG you had before. Anybody has an idea? TC. Yeah, TC overdose, and you see the wide, remember we were talking about AVR, a big terminal R wave in AVR greater than 3 millimeters. And then the final case, this 300-pound guy in a motor vehicle crash. You intubate him, he drops his blood pressure, you think he's has post-intubation hypotension, and then 2 minutes later he has no pulse. This is a narrow complex PEA. What's his problem? Tension pneumothorax. Again, you intubated him, and then shortly after that he develops PEA. So just always be on the lookout for that. So hopefully through this talk, I've convinced you to try not to use the H's and T's. I know we're all taught about it, but just to consider a new way to manage, think about PEA, teach PEA, hopefully come up with differential diagnoses and management strategies by using this, I think, rather simple algorithm. Okay, so it really eliminates however many H's and T's there are, a lot, and gives you, in my opinion, 4 things to really concentrate on. Or even 2, because it's either going to be narrow or wide. Okay, it looks like I have 10 minutes. Is that the case? Okay, I want to just go present a case really quickly. This will be very, very quick. And this is a case that I was able to present and review during my time as the medical director for the trauma agency. And again, if you ever feel like what you do doesn't matter, I strongly advise you not to feel that way. I know it's hard. We feel that way. You know, you're not alone if you feel that way. But this is a case that really, really shows that when our system works and when our providers come together, we can really make a difference in patients' lives. So this is a case that I presented about a year ago or 2 years ago. 911 call was received at 6:58 in the afternoon. Very shortly after that, fire rescue was dispatched. They started extrication of a patient in a motor vehicle crash at 7:06, so pretty quickly after they were dispatched. And then the ambulance got there shortly after that, and they got on the scene, and they had the helicopter on standby. They got on the scene, they see the scene, they say, yeah, we'll need the helicopter. The helicopter gets dispatched. The patient gets extricated at 7:20, and at that time, and this is how the helicopter note reads, is that they basically landed, walked to the field, walked to the car, and the patient was extricated at that time. So very commonly, like you guys know, we all sort of go into the ambulance, into the ground ambulance together to stabilize the patient, airway management, IV access, and what have you. So that's what they did. They walked into the ambulance together, and together they managed the patient. And so the patient's 47-year-old female. She was an unrestrained driver in a motor vehicle crash. The patient's vehicle was struck on the driver's side. There was a lot of passenger compartment intrusion, and there was steering wheel deformity. The patient initially was awake and alert, oriented, complaining of some dyspnea and left-sided chest pain. And like I said, the helicopter landed at the time of the patient's extrication. Okay, we did that. Here's the vital signs. The GCS was 12, the heart rate 103, blood pressure a little soft, 92/44, respiratory rate of 24, only satting at 91%. She had a 6-centimeter avulsion in her left temple, some cuts to her cheek. She was breathing pretty shallow and fast. She had subcutaneous air present on the left. So like crepitus, a little crunchy feeling on the left, and her lung sounds were diminished. So this is probably a simple pneumothorax, right? Vital signs are normal, relatively normal. And she has, evidence of subcutaneous air and evidence of a pneumothorax. Her belly was soft and non-tender, the pelvis was stable, and her radial pulses were a little weak. They performed hemorrhage control of the scalpel avulsion, put 2 big IVs like we always do, and for some reason her mental status deteriorated, and they opted for endotracheal intubation. So they did RSI, they used succinylcholine and etomidate. They intubated one time. Somehow they intubated the esophagus, but they recognized it right away. And then the second time they did it with a bougie and had a fine outcome. So she was intubated relatively easily. And that was about 7:30. So she was intubated at 7:30. And then at 7:31, they document some vital signs. Blood pressure is basically the same, right? We said it was a little soft, still pretty soft. Heart rate 73. SpO2 got better. So she's, I'm sure we've all seen worse. She's not all that bad off. And then 4 minutes later, the blood pressure is going down. They still note absent breath sounds on the left. The patient's hypotensive. She has subcutaneous air on the left. So rightfully so, they decompress the left chest. And they note immediate improvement in the patient's breath sounds. The blood pressure comes to 106/65, and the heart rate's 95. So they put her in the helicopter. They leave for the trauma center at 7:48, get to the trauma center at 7:56, and just keep in mind, the initial 911 call was received at 6:58. So we want to do it in an hour. We got it in 2 minutes, under an hour. So that's great, the way, the ground EMS works together, helicopter crew works together. This is a very, very nice scene if you picture that. So that was at 7:56. At 8 o'clock, 4 minutes later, by the time they get down the ramp and all this stuff, she arrives there with a palpable carotid pulse, blood pressure 110/60, doing fine. 8 minutes later, unfortunately, she loses vital signs. They put a ultrasound in her heart, like we do in the resuscitation bay. There's no cardiac activity. They open the chest. They do what's called as a resuscitative thoracotomy. They just open half the left chest. And then she gets return of spontaneous circulation, right, when they do that. So that's good. So then they take her to the operating room. They do a laparotomy. They say there's no injuries in the abdomen. They close up her belly. They close up her chest. They take her to the CAT scanner. And in the CAT scanner, she regained consciousness, opened her eyes, moving all extremities. And eventually the patient was closed up. She was found to have no injuries that are significant on the CT scan. And eventually discharged to a rehab center and then home. I don't know how she's doing now, but I'm sure she's fine. So anyway, that's a perfect example of when our systems work together. We have excellent patient outcomes. And in my opinion, what this patient had was a tension physiology, that they decompressed the chest with a needle, and then 20 minutes later, the needle probably clotted off. She developed tension again, and then that's why she coded in the resuscitation bay. So that's that case, and that's my talk. Does anybody have any questions or comments? No? Well, that's it. Thank you guys very much.